Welcome to the podcast series on innovative healthcare solutions sponsored by the Conference of Consulting Actuaries. Now, this is a series of interviews with professionals focused on delivering innovation in healthcare, and I think this is our sixth installment in this series. I'm sure you're going to enjoy this session and all the great discussions we plan to have highlighting the interesting people, products, and services designed to drive a better healthcare system. These sessions are offered to provide insights about what's transpiring in the ever-changing healthcare environment in which we live. And while these sessions are not necessarily designed to offer continuing education credit for actuaries, each viewer can assess for themselves if it meets that criteria for such credit. Hello, everybody. My name's Ed Podlowski, and I'm president of Morningstar Actuarial Consulting. I'm also the chair of the healthcare community within the CCA, and I'm going to be your host for today's discussion. I'm really delighted today to be joined by Mark Stadler. Mark is the CEO at AccessHope. Mark has a distinguished career in employee benefits as a consultant and as a leader in the innovative healthcare space. In fact, before joining AccessHope, Mark was CEO of Bridge Health. Mark, thanks for joining us today.
Hi, Ed. Thank you for having me, and nice to be with you again. It's always good to see you.
Same here. Same here. Hey, Mark, tell us about AccessHope and its genesis. It's knowing some background, it's a real interesting story.
Sure, be happy to. AccessHope was founded about 3 years ago as a department within the City of Hope, whose mission is to democratize cancer care. City of Hope was looking for ways to be able to export NCI, which is National Cancer Institute, level research and capabilities out to community-based oncologists. And they started working with large self-funded employers who were seeing variations in their cancer data and in their outcomes for people who were being treated in an NCI center versus out in a community center. And they found that the chances for survival were significantly better for people in an NCI center. Not everybody can get there. Only about 20% of patients actually find their way into one of the 50 plus NCI centers in the US. So City of Hope had a vision of how do we export that. When they saw success in the program, they spun out the company and formed AccessHope. I joined the company a little over 2 years ago as its formative CEO to build the company. At that time, we had about 30 customers and served about 900,000 members in the US. Today, we are really thrilled to be serving 81 large self-funded employers, including many of the Fortune 500, and we are serving about 3.5 million members today. Again, exporting NCI level cancer diagnosis and treatment assistance to community-based oncologists. We also now partner with 3 other institutions. We partner with Northwestern, the Lurie Cancer Center in Chicago, with the Dana-Farber Cancer Institute in Boston, and now with Emory Health down in Atlanta. And all 4 of us, including City of Hope, represent NCI centers and are working in cooperation to bring these reviews out to people on their cancer journey.
So Mark, talk about that a little bit. Go into kind of a little bit more detail about how this interaction with these NCI institutions helps to improve the quality of care kind of across the spectrum. Just give us a little more insights around that.
Sure. Well, so first of all, there is a significant, what we call a cancer knowledge gap. The field of cancer is changing very quickly and very, very rapidly, particularly when it comes to complex cancers, which are generally those cancers that are treated in these large NCI centers. It takes, on average right now, 73 days for many of the research situations to increase and to improve, and for new technologies and new treatments to come into the market. Many of the large carriers are using, guidelines that are published 15, 18 months ago, and they're making determinations for cancer treatments using old research. The same thing happens with community-based oncologists who might have access to the research, but have a very limited amount of time or staff resources to go through that research to find the appropriate treatment, or might even to find the right diagnosis. So what AccessHope is doing with these NCI centers is coming alongside these oncologists to pinpoint the correct diagnosis and to get people on the right pathway. And sometimes when you get the right diagnosis, there can be dozens of pathways, depending on other comorbidities for that cancer patient. And so the NCI center empowers that local oncologist to provide that level of treatment. It keeps the patient home where they should be. Because traveling into an NCI center, particularly during COVID, was very challenging. These are people with compromised immune systems. So we are able to bring that NCI level of expertise out. We partnered with our currently 4 partners, and we will be bringing on additional partners because the volume of cases is significantly higher. Also, we want to have people that are regionally based to guide people into clinical trials, which are also regionally based. So City of Hope may be aware of a clinical trial in New York, but doesn't have access to it like Dana-Farber would. So we can also guide people into those clinical trials where appropriate.
Mark, I know you've probably seen numerous studies like I have that suggest how there's been varying practices in care across country, just in all of healthcare, not just related to cancer treatment, both in terms of the utilization and the cost of those services, and how some of that really can't be substantiated just on the particular cases. I'm assuming that your model that AccessHope deploys is bringing a lot of consistency in how cancer is treated. Is that an accurate statement?
It has that potential to do that. So keep in mind, when we come alongside that oncologist, we're giving a recommendation. We do know in some independent research that was done that 85% of the time the oncologist is adopting our new pathway. We also hear from the oncologists that we're working with that they would like to have this kind of a program for all of their patients. Right now, we're helping them with people who might be covered under a plan that's sponsored by one of our employers that we're serving. We do know that we have an ability to impact mortality. We know that mortality rates from cancer vary by zip code. And if you think about what we're doing, it's frightening to think about, but your zip code really does determine your access to appropriate cancer care. Our program is agnostic to zip code. We use an algorithm to find members through their employer's claim data systems and identify those people, so we're blind to where that person might live. And so we're bringing this program and bringing to that patient and to their oncologist, regardless of their zip code. And if you look at some of the cancer mortality rates, again, it's significant variation by zip code, and we can cross over that. We're very proud of our ability to do that and to really help an employer from a diversity, equity, and inclusion perspective to really help them address that issue through cancer care. And the other thing that has to be taken into account in that regard is, you've probably seen some of these statistics, but 1 in 8 of us has an inherited cancer-related gene mutation. We now have ability, in our world to detect those through some early detections. But the other thing that we see in data today is that African-American men have 111% higher risk of dying from prostate cancer than white men. Now factor that into zip code issues and other things and the ability to reach out to these people. Bisexual women are 70% more likely to be diagnosed with cancer than heterosexual women. And it's a much greater focus on sexual health that I think is enabling this. But think about, the dichotomy there between heterosexual and non-sexual and bisexual. And then 34% of cancer deaths can be prevented if we can get beyond these socioeconomic disparities. And again, so the ability to cross over that zip code without, you kind of bust right through it with the claim data. Our hope is that someday we'll be able to do this beyond employer-sponsored health plans and to be able to assist populations in need through, could be carrier contracts with Medicare, Medicaid, and populations like that.
Right. You you talked about the consistency of care and the ability to impact health equity, which is obviously a major focus. But I'm sure the pandemic has had some effect on the delivery of service as well. I mean, we've seen, routine screenings having been reduced significantly during the pandemic, and the need for isolation away from the general population, which sometimes includes the healthcare system for things that are of a non-urgent nature. And I've seen some studies too that suggest that's also happening within the cancer screening area as well. So kind of curious to you, what's kind of been your experience within AccessHope, and what have you been able to do to try to combat some of those issues and try to make sure we're getting to treating these cancers in their early stages?
Well, we are very concerned about the alarming decrease in early diagnosis of cancer. So we are very, very alarmed by the increase in late stage first time cancer diagnoses. We see a sharp increase in stage 3 and stage 4 cancers being diagnosed for the first time, and that happened as a result of COVID. We encourage all of our employers to take action with some of the early detection programs that are out there right now. There's a number of programs, GRAIL being one of the most notable, that is doing the bloodborne diagnostic test so that you can identify that. The cancer centers right now are generally overrun with now people coming in seeking testing, now that we've sort of opened up our society again to this. So we're seeing higher volumes coming in. What we are trying to find is ways to be able to access those records more quickly, get to those people earlier. We've found ways to do that within our employer databases to identify the members more quickly. But it's really about the employer, I think, getting the word out to get in for screenings for people who have not been able to get them in the last couple of years.
Yeah, let's hope we're at the tail end of this pandemic and we can start getting back to normal preventive care, particularly on something with such serious nature as cancers. Yeah. Mark, I know the organizations that contract services with you, the large employers, do so because obviously they see a value in making expert information around cancer treatment available to their members. But I'm assuming there's also some potential opportunity for some savings as a result of this. Do you want to talk about that a little bit?
Sure. I will say the majority of our customers come to us, they're looking to make sure that people are getting appropriate treatment and getting diagnosed as quickly as possible. Financial savings, we know we deliver 2 to 1 across our book of business in terms of ROI on a financial savings perspective, but our customers are most focused on the humanistic value of the program. And if you think about, I'll give you a recent situation where we found a patient who was not diagnosed properly and was on an inappropriate treatment plan. And when they got onto the new treatment plan, it resulted in a series of 5 pill-formed treatments, as opposed to 5 years of chemotherapy that they were on that pathway. And they had already gone through months of chemotherapy. So you look at the future cost of 5 years of chemotherapy being administered twice a month, and then you look at the humanistic value to that individual who was on the road to a cure with 5 pills over a much shorter period of time. Their improvement in their life and their quality of life is significant. So the cost savings are significant, but that humanistic value, and we may just have saved a life that could have, might not have been the case with somebody going through that 5-year of treatment plan. We find that in about 70% of the cases that we look at, we have a difference of opinion in either the treatment or the diagnosis or both. And there's a range of variation between whether it's an extreme disagreement to minor, but in all of those cases, we do track them and we do quantify them for our customer using a kind of a predetermined formula, if you will, that allows you to put some value on it. One of the things we're also the most proud of is that we do a net promoter score for our members as they come through. And we've targeted a goal of 70 for our NPS, and we're achieving above 85 right now in terms of NPS. And it tells you, it speaks to the value to the member who has the peace of mind, even when our approach may agree with the path they're on, to have that kind of confirmation that you're on the right path. And then when you're on the wrong path, certainly to know that you have now an opportunity to get on it is terrific. We are in a recent study that we did with the JCO oncology practice. We looked at a particular area of cancer subspecialty, and in 93% of the cases, we provide evidence-based recommendations associated with that delivered much more positive outcomes, improving efficacy, reducing toxicity, and enhancing care. And of those cases, 85% of them were with community-based oncologists that we were touching upon. So we feel, and they also yielded about $19,000 of savings per patient across that entire population of cases. Wow. As our volumes grow, we will continue to do this level of evaluation. Our clients are doing independent evaluation. Again, not so much to justify the ROI, but to understand what's the impact that you're truly making.
Right. Mark, is there anything that I didn't ask that you would have preferred I asked?
I think where we see the future going in cancer research, again, it's changing, it's moving much more rapidly. We are seeing opportunities to engage in earlier stages in what are typically known as treatable cancers like breast and prostate. Typically, we have not found or not felt that we could add a significant value there. We are finding now that we can, but with these certain subspecialties. So it's really important that people are looking at all types of cancers, not just critical and very specialized cancers. The improvements that are happening right now with early detection is significant, and the volume of those. I think that people should really be watching the results of these early detection programs, because they have real hope for keeping people from moving beyond stage 1 cancers and perhaps getting them to cure earlier.
Right. Well, Mark, I like to always end these interviews up with a little bit of a personal question, and so I'll ask of you what I've been asking all my interviewees before this. If you didn't do this as a career, if employee benefits wasn't something that you get into, what would you be doing?
Oh boy, I'll probably make you laugh, but I'd own a garden center.
Oh, wow.
I'd own a big landscape nursery. Do something that makes people happy.
Well,
but I'm very thankful I'm doing what I'm doing. I think I have the greatest job in the world working with people with cancer and helping them find a cure.
Well, if you ever open up that garden center, let us know. You'll make a lot of money off us, I'm sure.
I spend a lot of money at them.
Well, I'd like to encourage all of our viewers who also participate in our healthcare community to continue any discussions about the insights shared here on that platform. And if you're not a member of the CCA, and you might want to consider joining to not only experience the benefits of the community platforms that I just mentioned for those informal discussions, but all the other great benefits our members enjoy. Mark, really, thanks for being here today and sharing your experiences about AccessHope and what you're doing to drive innovation in healthcare. I'm sure our audience benefited from the time you spent with us, and I know I did. Thanks again.
Thanks, Ed. Great to see you.
Take care.
Bye.